you all very much for coming tonight. My name is Jeremy Ader, and on behalf of the Healthcare Improvement Group at the Yale School of Medicine, I'd like to welcome you to this event. I would first like to thank all of our generous sponsors who've made this event possible, including the Benjamin Rush Institute, the Arthur N. Root Foundation, the Yale Graduate and Professional Student Senate, the Yale Healthcare and Life Sciences Club, and the Yale Institution for Social and Policy Studies, Health. I would also like to thank all of the students who put so much work into making this event possible. Healthcare payment reform is and will continue to be a crucial part of the conversation about how to best provide cost-effective and high-quality healthcare. And tonight, we are fortunate to have four very experienced speakers address the topic, how should doctors be paid? The future of physician compensation and the role of government. Apparently, and Dr. Foreman let me know this, on one of our listservs, the title got shortened to, Should Doctors Be Paid? So if anybody's here because of that email, we wanted to offer our sincere apologies and let you know that the talk on the revolution will be saved for a later date. So without further ado, I'd like to introduce our speakers. Zach Cooper is an assistant professor of public health and of economics at Yale and the director of the Institution for Social and Policy Studies, Health. Dr. Cooper's work focuses on the intersection of public policy, healthcare, and economics, and he has looked at the impact of a number of factors on healthcare pricing, productivity, and quality. John Graham is a senior fellow at the National Center for Policy Analysis, the Fraser Institute, and the Independent Institute. He has served as vice president of research, payment, and healthcare delivery policy at the Advanced Medical Technology Association, and his articles have appeared in the Wall Street Journal, Washington Post, Forbes, and the National Review. Neil Minkoff is the chief medical officer of Impera Med, founder of Fountainhead Healthcare, and a former commissioner of the Massachusetts Group Insurance Commission under Governor Deval Patrick. From 2004 through 2010, he served as the medical director for Network Medical Management and Pharmacy for Harvard Pilgrim Healthcare. Dr. Minkoff trained in internal medicine at the Leahy Clinic and practiced as an internist. Robert Nordgren is the CEO of Northeast Medical Group and a senior vice president of Yale New Haven Health System. He is a board-certified pediatrician and was previously an associate medical director at Dartmouth Hitchcock Manchester, and also served as the executive director of Child Health Services in Manchester. Our moderator tonight is Dr. Howard Foreman, professor of diagnostic radiology, public health, management, and economics at Yale. Dr. Foreman is the faculty founder and director of the MD MBA program, as well as the director of the School of Management's MBA for Executives program. Dr. Foreman is a practicing emergency radiologist and is actively involved in patient care and issues related to financial administration, healthcare compliance, and contracting. Dr. Foreman?
Thanks to you all for coming, and really thanks to the Yale Healthcare Improvement Group and all of the societies that have sponsored and supported this event. I personally entered the residency match 26 years ago, and at that time, we already had most of the literature developed about physician compensation and the incentives that were created that changed physician behavior, and yet many physicians at that time were very, very skeptical about how much physician behavior was impacted by financial concerns. And you skip ahead now, and the question really is whether physicians respond to anything but economic considerations. And it really is. It is an amazing change over time that people now at least accept this, and in many cases have a hard time seeing anything else that might influence physician behavior. I mean, clearly it overstates the issue, but how physicians are compensated has very broad implications. You know, number one, how well we can serve the public. Related to that, how does the workforce of physicians match the clinical needs of the population? And then can private and public health insurance costs be brought under control so that our nation can continue to be competitive globally and continue to raise the standard of living? I noted that 10% of our graduating class this year at Yale was pursuing dermatology, which is dramatically disproportionate to, I see somebody happy there, dramatically disproportionate to the number of dermatologists in the country, and it's quite a noble profession and one that really gains a lot from the talent that Yale could provide, but it does beg the question of why such a huge number of students from an elite medical school are pursuing a relatively small specialty, and then conversely, how do we have a successful healthcare delivery system when the best and the brightest are not in the front lines? And so it's just one of the thoughts that comes to me as we begin this conversation. We have an incredibly talented panel and of physician and non-physician thought leaders, and I think a great job has been done assembling this. I know this will be an interesting discussion. We're going to make sure that we have enough time for the panelists to present their viewpoints, be able to respond to each other, and then be able to take your questions both as given to us by text message and before the conference. We have a list of accumulated questions, and so we're going to try to have a nice, vigorous discussion over these, over the next 75 minutes. So with that, we begin with Dr. Nordman.
Great, thank you. I have the privilege, I guess, of going first, which means I can really say anything I want to, and that's great. But I do have a little bit of a blank slate. And going first, you know, I wanted to frame some of this discussion, and because I was going first, I thought I would take the opportunity to do that. And so we're talking about physician compensation. And I think we need to be clear about, first of all, what is physician compensation and what is it not. Physician compensation is not a strategy. Physician compensation is not our values if you're running an organization, whether that's a small two-person practice, you know, down on Chapel Street, or whether it's a large faculty group or a group that's part of a health system. It is not a strategy. It is not a set of values, but it is a management tool. And it's a tool and a practice to reinforce those things. So I think when we talk about physician compensation, what we first need to be thinking about is, what is our strategy? What are the values that we want to see in our healthcare system? What are the behaviors we want to incent? Because I see it every day. I literally was on the phone from 5 to 5:30 before coming over here, talking about a physician compensation contract because we're trying to incent certain behaviors. And so when we think about physician compensation, I want to put it in that context and make very clear that whatever you end up doing, and we've got some very impressive leaders up here at the table, myself excluded, what are we really trying to incent? Because I think, when I think about the medical group that I run and I think about physician compensation, I think about what are the behaviors we're trying to incent, and behind that, what are our values? What are the values of the organization that we're running? And again, we're talking big picture here about our healthcare system. What are the values we want to see in our healthcare system? What is the strategy? We're going to talk about healthcare policy strategy. What is the strategy we want to have going forward to hopefully create the best healthcare system that we can? So that's a little bit of background. And I'll tell you, just quickly, Northeast Medical Group, the group that I run, we are going to embark on a physician compensation reorganization. We're going to come up with a new physician compensation model, at least I think it'll be new, over the next 6 months. And I've been talking to people internally, and just to make the point that I'm trying to make, that conversation is starting with what are our values. So we have a values and a mission, vision, values statement, and our compensation discussion is going to talk about that first. And then also talk about our strategy. Where do we need to be as a medical group 2-5 years down the road? And we should design our compensation structure to get us there, not the other way around. And so I think, I just want to give some of that background to put that around our discussion today. The other piece of background that will lead to what I'm advocating this evening is change. Our healthcare system, we all know this, is changing rapidly, and whenever I talk about change in our healthcare system, I always point out that I do not have a crystal ball. I think directionally, though, we can tell, we know the direction we're going in. What I mean by that is there are a lot of payment models out there right now. So I can tell you in the Yale New Haven Health System and Northeast Medical Group, we're doing bundled payments, we're doing shared savings, we're going to be an ACO in the next 6 months. Oh, and by the way, we're still mostly paid fee for service. So try to design a compensation plan around that. And that gets to one of the things I'm going to talk about in a few minutes, which is I think your compensation plan needs to be flexible in the sense that nobody has a crystal ball, and how we're really going to be reimbursed in 5 years from now in healthcare. There's a lot of change happening. The other thing that I would say about healthcare is we really need to look at how physicians are practicing day to day. And there's a lot of change happening there as well. So all of these points lead me to say, what I believe is the best model is a salaried model. I think if you look at some of the best organizations across this country, Mayo Clinic, Cleveland Clinic, they have a salaried model because it gives them flexibility, and they recruit into that model. Their strategy is to recruit physicians who want to work under this model and provide the best care, and then they can incent people with some metrics on top of that. But the bottom line is, I think with all the changes happening in healthcare, where I think we want to be going in healthcare, a base salary is the best way to go in terms of having really something that's going to be flexible, adaptable in the future, and is going to be parallel and complementary to the strategies that we need to have as health systems going forward. My time is up, I see. That was fast. Okay.
All right. Hi, everybody. So thanks, Jeremy, for organizing, and Phoebe, too. Where's Phoebe? Is she out there? Oh, there you are. Okay, you're the one. Oh, so I really have to thank you so I don't get in trouble. So delighted to be here to talk about what I think is really one of the core issues in domestic U.S. policy, which is how we begin to rein in healthcare spending and how we begin to really rationalize the way we pay doctors. I actually had a similar experience with Howie vis-a-vis the how we pay doctors. I was down at a wedding this weekend in Charleston, and I had my notes out. I was prepping it, and the title was How Do We Pay Doctors? And I went to go get a cup of coffee. My best friend, who's a vascular surgeon, came back and crossed it out and basically wrote generously in large letters and circled it. He said if I wanted to win the debate, that was what I would be advised to say. So I've been asked to make the case that government should play an active role. So rather than saying pay this way or pay that way, make the case that the government should be an active, if not the dominant driver of the change we need to see. Now, I think everybody in this room is going to know that we spend more on healthcare than every other nation. And in and of itself, that's not a bad thing. The challenge is that it's not clear we're getting value for that money. Okay? We do well on some measures, but across a bevy of other outcomes, we perilously far behind. We lag behind Greece in life expectancy. The World Health Organization ranks us 37th behind Oman, Paraguay, and Morocco. Apologies for anybody from Paraguay out there. And I think it's fundamentally clear why we spend more. And the reason we spend more is that at every sort of nook and cranny of the system, the incentive is to provide more care. We've got a malpractice system that scares doctors from being conservative and not taking that next step. We've got insurance that's become progressively more generous over time, and a patient body that's much more sensitive to quality than they are to price. And then fundamentally, it's the issue that I think everyone agrees about, which is it's the way we pay for healthcare. We have a fee-for-service system, both in the public and the private sector, that pays for volume, not for outcomes. And so I think fundamentally the question in this debate is, what's the most effective way over the next 5 to 10 to 15 years to transition from a system that pays from fee-for-service towards a system that probably looks like salary or capitation of bundled payments, and who's going to be the most effective body to drive that change? And what I'm going to argue, as I've said before, is that government should be, if not the dominant player, a very, very big part of this transformation. I think it should be for 3 reasons. The first is that when it comes to modernizing payments, size matters. You need a body that's going to transform payment who can reach every provider in the nation. And what we have right now on the demand side is a bunch of small insurance companies that each in and of themselves don't have the power to affect that kind of change. The second reason that size matters is we don't yet know what the most effective payment system looks like. We're going to have to trial. We're going to have to test new systems. That's going to require investment. And the only party who's going to spend early for benefits down the road, I think fundamentally, is going to be government. I think second, there are equity efficiency trade-offs. And I think that does necessitate a role for government. And I think third, the government right now is on the hook in the form of Medicare to the tune of $600 billion annually. And just from a practical perspective, that buys you a seat at the table. So I think we're going to hear that private providers should drive the innovation. I think that sounds great. I think the challenge, we've seen no evidence that they can. All of the big innovations, okay, the DRG payment systems, bundles and capitation, pay for performance, have actually been driven by public sector payers. And so I like the private sector. I think they have a role. They need to demonstrate that they can drive the innovation process if we're going to put more money into what they do. You're also going to hear that we should get rid of third-party payments. Okay, that if we just got rid of insurance or we switched to catastrophic coverage, that would make fee-for-service look more appealing. I think first, we're never going to get rid of third-party coverage. If we did, we'd bankrupt virtually half of American families. But I think it ignores the fact, fundamentally, that big players are the ones who drive change. And I think the example of this is Walmart. Okay, it took Walmart to fundamentally get the barcoding system to be ubiquitous. That's the type of change that we need in healthcare. We need that one dominant player who comes in and says, this is unacceptable, we need change. So how do we think about this? I think the most fundamental way to think about modernizing payments is to think along the lines of how we've invested and conducted R&D in the medical technology space. Okay, the last 50 years have been about the science of medicine, the new discoveries, new technology, new conditions, new drugs. The next 50 years are going to be about the science of how we deliver that medicine. It was the NIH that funded a lot of the research that's manifest in drugs today. And it's going to be the federal government who pays for the innovation, or the R&D that figures out what innovation works. And probably it's going to be the private sector that operationalizes that change. So does this mean there's an equity efficiency trade-off? Yes. But that is fundamentally the cost of having a system where we do have doctors in Montana who are focused on emergency care, that absent government, we need a guarantee that every provider is motivated not to go into dermatology, despite our guy in the 6th row there, which is okay, I don't know. And that absent government playing the dominant role, we're not going to have an ability to guarantee that care isn't delivered fundamentally on the basis of ability to pay, when we really care about care funded based on the patient's needs. So that's why I think fundamentally government needs to drive this process.
Thank you. With all this talk about dermatology, I'm having a Seinfeld rerun flashback that most of you are way too young to know about. So much has changed since I was in medical school, technology, practice style, etc. It is refreshing to know that some things stay the same. The most dangerous spot in any hospital is between a medical student and the buffet. So I'm going to start off by saying that in many ways I agree with Professor Cooper in terms of framing the problem. Medicare is a gigantic problem, and Medicare does have the huge scope issue. It does earn them a seat at the table. I don't think that's easy to deny. Having said that, I would approach it somewhat differently and try to free it up to create some innovation. Medicare being by far the largest payer of health care claims in America and the world, the Medicare fee schedule drives the market for everything else. The private payers adopt that fee schedule in many cases and use it to create the physician compensation that they're paying for different fee-for-service models. In essence, this can set a floor for clinical reimbursement, where clinics and providers set budgets based on expected revenue rather than on the cost of providing services, actually doing activity-based costing to find out how much it costs to treat somebody for a condition and adding an appropriate margin on top of that. Patient experience, convenience, and quality of care do not significantly affect clinical reimbursement in the standard traditional Medicare program. There is therefore little to no incentive to find ways to create new value in the system. By law, the physician or hospital cannot charge a Medicare recipient premium pricing for a service or procedure. I first became aware of this and noticed it while treating a patient between 15 and 20 years ago. I was, I believe, in my second year of practice at a poorly run community hospital that was soon to close, treating a patient with a pulmonary embolism. I was transferring this patient to arguably the world's expert on embolism, Dr. Sam Goldhaber at the Brigham, which is consistently rated as one of the nation's top hospitals. Medicare paid both of us the same amount for that. That's wrong. That encourages a sense of care that is good enough. Outside of integrity and drive, Medicare and the system behind it does not give an incentive to develop, improve, or excel care. Only recently has Medicare started to pay any attention to outpatient quality of care through the physician quality reporting system, and even then, caps payment and has a small punishment, a reduction in fee for not hitting your quality targets or reporting them. However, it also, it can often cost more to collect and report that data than it would the incentive to do so. We are aware that Medicare is experimenting with new payment systems such as ACO and bundled payments. Those are done around the patient, and the patient is oftentimes unaware or unable to affect the decision of a provider to enter into one of these alternative payment schemes. The setting of the Medicare fee schedule exempts much of medicine from supply and demand rules. For example, over a 5-year span recently, Medicare reimbursement for cataract surgery rose from about $900 to about $1,050, which is a 17% increase. However, there's a growing volume of people hitting the age and the incidence of cataracts. In a sane free market, the price would go down as the volume expanded to get access to those groups of patients. Conversely, elective visual surgery correction dropped. It's harder to get those data. You have to do a lot of searching. It's not on the CMS site. Decreased approximately from $2,100 per eye to about $1,700 per eye, which is a 20% decrease, thereby making that an over 35-point shift in terms of how cost is affected when it was driven by Medicare as when it was driven by the consumer. Payment not based on individual experience could account for another example. Ever since the lap chole was invented and became the standard of care, the risk of tearing the bile duct, which was the major complication, has dropped. It has plummeted because that is the most costly complication that can be made. But the risk of a small complication, like dropping a stone into the abdominal cavity, hasn't changed since lap chole was introduced because there has been little to no incentive to do that. So an irrational one-size-fits-all schedule that does not reward quality, patient experience, or clinical expertise traps the public in a medical system where one is rewarded for doing things, but not necessarily for doing them well. Thank you.
Well, thank you. Thanks for having me. It's great to be back talking to the Benjamin Rush Institute. I have a background with the Benjamin Rush Institute. And before I start, this is not vanity, but I do actually have 2 degrees. But neither is an MD nor a PhD, so I'm happy to let that slide. I'm also going to approach this quite humbly. There's a professor of law I know at University of Illinois in Chicago, Dave Hyman, who pointed out to me, reminded me something of which I should be very cognizant. When you're talking about a professional, it's not really possible to define the perfect payment system. Right now, the job I do, I'm on a salary model, but I have been on a fee-for-service model, i.e. as a contractor, and there were some incentives under that system that made me a better policy analyst than as a salaried person, but vice versa. There's some things that do me better. Nobody dies if I get it wrong, but there's no perfect way. But let me attack my presentation here by addressing that I think we might have, if you'll forgive me, you all are medical students and I'm not, but we may have misdiagnosed the problem here in terms of fee for service. And for many years now, it's all day long at any meeting, any conference, any article, you'll read fee-for-service is the problem. A key example was Hillary Clinton, who just recently at the annual meeting of HIMSS, which is the Health Information Management Society conference, the IT geeks of healthcare, she said in her keynote speech, "How will we stop paying for quantity and start paying for quality?" And that sentence, or a version thereof, you'll hear day in and day out. So let me start by, I suggest this is a misdiagnosis, and let me give you a little case here to kind of illustrate. A little over a year ago, there was an article in the New York Times describing the journey of a woman who had broken the shell of one of her hearing aids, and she was shocked at the price that hearing aids costs, at least $2,000 for a set, and usually $3,000 or up from audiologists. So she sought another solution, and she learned that about 70% of the price of getting your hearing aid from an audiologist is markup. And so she went around and found online vendors of hearing aids, Costco, Audicus, where she could get them for as little as $3.99. Searching a little more, she found an audiologist who offered to repair the shell of her old hearing aid for $100, so that's the choice she made. But then the point of the New York Times article was only a year later, after this new technology was allowing entrepreneurs to develop hearing aids that they plan to sell for less than $300 and have better sound quality than ever. And now we hear of online hearing aid apps that you can buy on iTunes or the Android store that can sell for $3.99. Now, I'm not vouching, I haven't tested any of these things, so I can't aver for the quality of them. But that's an interesting development that is not the kind of development you usually hear of in American healthcare. And there is a small number of children who use hearing aids, but mostly they're marketed at seniors. And the punchline of the story is that Medicare does not cover hearing aids for seniors. And therefore, even though it's taken a long time, innovation has led to price competition and reduction of costs. The other interesting thing, of course, the issue of buying a hearing aid app on your iPhone or your Android. Almost everybody has an iPhone or an Android or some kind of smartphone. And I spend a lot of time at conferences where people talk about mobile health technology and how do we get the best mobile health technology into underserved populations, very low-income communities. And they think that mHealth technology is going to be killer app because almost everybody in a very low-income community, even if they don't have access to health care, has a smartphone nowadays. And how did that happen? What role did government play? Very little. I mean, in the 1980s, they deregulated the telecoms market, is what they did. But it's very much a free market, and you see the prices going down, and that is what gives universal access to these technologies. Low prices, not more and more government programs designed to give people new technology. To give a more general case of what we're seeing in American healthcare, between 1950 and last year, prices of medical care went up 2,700%, whereas prices of general goods and services in the CPI, Consumer Price Index, went up 800%. Price of medical care up 118%, price of physician services up 92%, price of all goods and services, this is from 1992 until last year, up 64%, cosmetic surgery up 30%. Well, that's fee for service. And I see I've got 30 seconds, so I'll close and leave the rest of my notes for the Q&A. There's a doctor called Linda Halderman in Fresno who's a surgeon, and she did, most of her practice was biopsies for women who had lumps in their breasts, and she was sending them in to be tested. And Medi-Cal, the Medicaid program in California, was the payer. It was fee for service. She couldn't keep her doors open doing that. They just weren't paying. They were paying like, I think it ended up paying $12 or something each time a patient came in. So she started doing the Botox injections. And that's how and then eventually she thought it was just too painful for her emotionally and professionally to be giving Botox injections, fee for service at a profit, versus seeing these breast cancer patients and getting fee for service payments from the government and not earning a profit. So I'd like to close again by suggesting it's not the fee for service, it's who is the payer. And once the patient is the payer, I think we solve a lot of the problem. Thank you. Wow, I got through about 1/4.
So I think we're going to start from your microphones with 2-minute rebuttals or comments on what the panel has already spoken. We'll go in the same order that we started.
Great. So I'll start off with a couple of ideas that we didn't really get into, I think, in the initial comments. And the first idea would be, I do think if you look at how physicians are paid today, it does influence how we practice medicine. So I'll give you one example. I practiced pediatrics for 10, 11 years, and when I was helping run a clinic up at Dartmouth, I pointed out that about 40% of the patients we saw on a given day didn't physically need to be there. It was something we could have done with the right technology over a video visit, an e-visit. Why were they there? That's the only way we got paid. And I think that, so if we do need to accept the fact that how doctors are paid will drastically impact how we practice medicine. The second notion I would put out there is I think that it gets very difficult to parse payments, and I think one of the issues with our whole fee-for-service system is it's really, it doesn't let health systems or even physicians think about what are the best way to take care of these patients. Because innovation can happen, but innovation will only happen if folks that are on the ground have the freedom to do that. And what I'm getting at is, I think the best way for folks to be paid, whether it's hospitals or physicians, would be to really do some form of capitated payment. And the reason I say that is that if you turn the money over to physicians and hospitals, let them figure out the best way to deliver care. I'll tell you right now here in Connecticut, right down the street at our emergency department, our system in Connecticut for Medicaid is fee-for-service. We, the Yale New Haven Health System, have said repeatedly to the government, we know we're not providing good care to the Medicaid population here in New Haven. I know there's at least one lawyer in the room, so don't repeat that. But so the point I'm getting to is we have said to the state, give us a lump sum of money, because we know half the people coming into the Yale New Haven ED who have Medicaid don't need to be there. Why are they coming there? Because there are no incentives to provide better coordinated care. And I think if you hand the money over in a global budget or capitated system to the providers, we will come up with a better way to provide care.
So I want to talk a little more about this question about whether or not giving patients more control, asking them to pay a little more money, is what's going to rationalize the way our health system runs. I think fundamentally we're in a debate between where in the spectrum so at one extreme you have healthcare doesn't work in a market, that it's not susceptible to market forces, and as a result the government should have a very, very active role. To the other side, which is that it looks like the market for apples. And our sort of thinking about where it sits on this spectrum informs a lot of our policy. And I think the best way to think about this is to look at other examples where we actually ask individuals to pay more. So England's a great example. Patients don't pay more, and the cost for a hip replacement is about 1/4 of what it is in the US. So in the private sector, where individuals pay more than they do in Medicare, the price is about somewhere in the neighborhood of 125 or 25% more than it is in the public sector. And the question is, to what extent will making people pay more reduce how much we spend on healthcare? And the key statistic here, the one that I think is the most fundamental statistic in healthcare policy, is that 70% of our healthcare dollars are spent by 10% of the population. These are people who are spending $7,000, $10,000, $20,000, $30,000 per year on healthcare. And the idea that these people who are coming in with an MI, who are coming in with very, very severe cancer, that they would cost shop and cost compare, and that this is what would control healthcare spending, I think is frankly a bit silly. Because at the end of the day, what is driving prices to go up isn't patient choices. It's doctors' pens. It's you guys. And unless we fundamentally change you guys to a salary system or a system that rewards quality, the way you get rewarded is by doing more. And it's not the patient who decides what they get. Maybe in the case of hearing aids. Hearing aids aren't the reason American healthcare is expensive. American healthcare is expensive because of drugs like Avastin. And ultimately, it's not going to be me who's the consumer deciding whether or not I get Avastin or how much I pay. It's you. And so the incentives in the system have to be focused on you, who are the sources of high spending.
So I continue to be shocked at how much we're actually agreeing. So sorry if it's not as much of a debate as you were anticipating, maybe. A few principles I'd like to lay out there. The physician compensation should be transparent. That's a big part of this, right? On some level, say your doctors are going to salary, but with incentives. Those incentives matter. And it should matter to the customer if the doctor is being incented on number of visits or quality of care or some combination thereof. Since right now, the incentive in most of medicine is just more visits. That needs to be something that the consumer can choose around. And that's one of the concerns around ACO and IDN creation, is that they're being done secondarily without the consumer being part of the process. Another issue is that there needs to be the freedom to experiment with these new systems, but that's been going on for quite some time. I mean, my favorite example of what Reggie Herzlinger calls a focus factory is the Texas Heart Institute. And the Texas Heart Institute developed basically bundled payments in cardiac and cardiothoracic surgery back in the late 70s or early 80s because they saw a hole in the market that they could fill and reduce costs while improving quality of care. And they took this idea and they brought it to Shell and other large oil companies, it was Texas, and created a new kind of carve-out for cardiac care that was exceptionally good quality and reduced costs to well below the market rate. And last thing I'd say is that one of the reasons that the private sector pays more is because the public sector underpays.
Thank you. Well, I'm glad Dr. Cooper brought up this fact that almost all medical spending is driven by a very small number of patients. And that's always, or usually the rebuttal to my sort of argument. And I remember, as you were saying, like 26 years ago when this whole argument about, well, physicians' incentives are important to their behavior. And at that time, the physicians community rebuttal was things like, oh yeah, if people knew how expensive cancer was, they wouldn't get it, right? You know, that was kind of the way they tried to avoid that conversation. But if you look at things like, there's the Burumgrad Hospital in Thailand, you know, if you study the medical tourism market, the cost of American healthcare is so high that it is impossible to think of ordinary people paying for inpatient hospital services. But if you go to places where they do high quality, you know, these are all credentialed operations like the Burumgrad Hospital in Thailand, and there's others in Asia. And American patients go there and other patients go there and pay out of pocket a fraction of the cost for highly complex procedures that they do in the United States. And of course, if you want to get, an American has a lot of problems getting, if you have, say, some kind of cardiac surgery that would be very expensive, as an American, you'd have a very difficult time getting a bundled price quoted to you to get that done. If you were a Canadian who was, you know, waiting for 3 years to get it done in Canada, you wouldn't have much of a problem getting an American hospital to quote you, say, we'll do that for $10,000, $15,000, whatever $1,000. The Prime Minister of Newfoundland had it done a few years ago and it created a big scandal. All the MD Anderson Cancer Center in Texas has a whole office of people who speak Arabic and whatnot, whose job is to market their services to out-of-country visitors and the Spanish-speaking consultants as well, to sell their services, and they quote bundled prices for which, now these are high-income people, but the Canadians who come down aren't all high-income people, they're middle-income people. And so you can, even these highly complex procedures, markets can work, and I think if we let them work a little more, we would see prices come down. Thank you.
So, you know, Medicare is now 48 years and 3 months into its implementation, and Medicare, ironically, has been the leader in physician reimbursement. Whatever Medicare has done has been, you know, at least for the last 25 years, has been loosely followed by private health insurers. and even practices now base their fee schedules very much on Medicare. So much of the change that has occurred in reimbursement to physicians as well as other providers has been driven by the Medicare program. And yet we've seen very, very slow incremental progress in the direction that we'd like to see. We've seen Medicare make really aggressive efforts to change the disparity in reimbursement to primary care versus specialties. I remember 20 years ago, nobody wanted to go into radiology because Medicare said that radiology needed to come down and primary care had to come up. And 20 years later, if anything, the problem is worse. And Medicare has made aggressive efforts at changing reimbursement schemes. And so it kind of raises to me, a couple of issues. One is that the government is heavily involved in healthcare delivery right now, healthcare financing and healthcare delivery right now. And probably the only way that we can start to see change is by some type of regulatory change. Now, one could argue, as I would imagine, although I don't want to put words in his mouth, as Captain Graham, I'm giving him that title, as Captain Graham might argue that we actually need less government regulation. We need to actually unleash the, the free market and animal spirits to allow better competition out there. But something has to happen in order to make change. And I would ask each of you, if you had one thing that you would like to get either Congress to pass or some other major change to occur in the next couple of years, what would it be? Because otherwise I'm hearing you all tell me about great examples. It reminds me of my one great moment at the White House with the other 15 health economists advising on healthcare reform, sitting around the table, and everybody had great ideas, but they kind of went nowhere, and very, very little true innovation is built into the ACA. And we're counting on pilot projects to help us, but very little has happened, and that was 4 years ago yet. And so I'd love to hear from each of you an idea of what we can do to kind of change, and we'll start in order again.
So yeah, I'll make a couple quick comments. When I gave my introductory talk, I said I didn't have a crystal ball, but that doesn't mean I'm not afraid to make some predictions. So I do believe, now this isn't a change I would make, but it is, I think, relevant. So I think what we're going to see is some of the pilot projects happening with Medicare now are really going to produce some results. I'll give you one example, bundled payments. Yale New Haven Hospital, we just in our health system started the bundled payments program 7 days ago on April 1st. I would make a prediction that you're going to see double-digit cost decreases through the bundled payment program. And I think if you look at some of the early data, to me it's not a question of how much money is going to be saved there. I'm sorry, whether money is going to be saved, but just how much. And I think we're going to see very, very significant changes there. But the change I would make is related to another pilot program, and that's the ACO project. I was at an AMGA conference most of last week, and the AMGA had a lot of influence on the ACO legislation, and what they're pushing for now, which I agree with, is really some tweaking of that program. So what you're seeing is issues around patient attribution, some of the methodologies and incentives. So if I could have one change, I think the ACO program is going to show some very positive results. A lot of people are looking at the first-year results and saying, oh, it's not really working. If you've run a medical group, you know that the changes you need to make take 2 to 3 years. I think you're going to see significant savings through the ACOs, but some of that methodology needs to be tweaked.
So I'm going to answer your question by saying what I would change, and then I want to talk about why that change has been so hard to operationalize. So I'll give you a very, very simple example. The price of delivering chemotherapy depends hugely on where you deliver it. Same drug, same delivery, and if you deliver it in a hospital, it's about twice as expensive if you deliver it in a clinic. That's a simple change that would save billions of dollars, and the question is, why doesn't that change happen? And the answer is the way to think about healthcare spending and why it's hard to reduce is that $1 in cuts and savings is $1 taken away out of somebody's salary. And the challenge is we've got a medical industrial complex that's very, very good. It's the most heavily lobbied industry in America at blocking change. And we've decided to have Congress, in their infinite wisdom, be the body that determines how Medicare sets its payments. So we've seen the doc fix and the SGR stuff, which we can talk about. So what's the fundamental change that I think would make a difference, Howie? It's a Federal Reserve for healthcare. Okay, it's taking healthcare out of electoral politics. It's setting it on 5 or 10-year cycles. It's worked for interest rates. We've done a pretty good job there. I think fundamentally getting healthcare further away from politics is what would allow us to make those changes that we need to see happen.
I do want to just give you my one little anecdote about that, because in 2001 and 2002 I worked in the Senate, and that was a very, very contentious issue, reimbursement for oncology drugs, Part B prescription drugs. And I had about 72 oncology nurses in a very, very small conference room confronting me. I was thrown in there as the physician. I was the one to defend the office on this particular issue. So I agree with you fully. I remember this very well.
So I'm going to, I wouldn't say cheat, but be creative in my answer here and try to do a two-part wish. So the one thing I would change is two things, which is to, and they also include the doc fix, which would be to change the Medicare payment rate. So whether it's part of the doc fix or involves any other cuts, and to take a fair amount of that and put it into the physician quality reporting system, so that there is actual real money tied to the quality of care that's being provided, and that to really be able to be sustainable in Medicare in the practice setting, one would have to do both the visit and the good outcome, which I think would be revolutionary. But the second part of it is we need better quality measures. So I was working on a bundled payment program up at an orthopedic focused factory in the Boston area, and we were looking for what quality measures we should attach to it. And we went through PQRS and NQF and National Quality Forum and the National Committee of Quality Assurance and all these different organizations that do quality measurement, and we found that there were exactly 0 for orthopedic surgery, which happens to be a pretty significant trend driver on the outpatient world. So we can't get to the point where we can reward people on quality, practices and physicians on quality, until we start measuring it effectively in the things that are really meaningful trend drivers.
I just say, I'm making one more rule. If anyone uses an abbreviation for anything and you don't spell it out, I want $1.
Hey.
So
economic incentives again.
You see how the payment reform works?
That's right.
But just to clarify on some of those points, seriously, when we go through it, I just want to spell things out, but I do think it's important. You know, accountable care organizations are a critical part of what we hope is healthcare reform moving forward. And we're going to spell things out as we go on.
Well, I guess I'm here as sort of the ultra-libertarian unrealist, but if we're thinking of something that can be done in 1 or 2 years, and again, I want to be careful in hedging my remarks. I don't think this is a silver bullet or anything, but it has been talked about and it's been put forward. Medicare, there's 4 different parts, but the 3 parts that count are Part A, which is hospitals, Part B, which is physicians, Part D, which is drugs, and then if you bundle them all together, you get Part C, which is Medicare Advantage. I would mush together Part A, B, and D, because I don't think you're going to get the kind of incentives right that these folks are talking about until you do that, because the way the payment systems are done are completely different. So that's what I would do. I'd mush them together into one Part A, B, D. So
Medicare Advantage is the mushed together version of A, B, and D. So just pushing back on that, why haven't we had great evidence that that is a cost-saving, high-quality option? We have, you know, what do we have right now? About 28 or 29% of all Medicare beneficiaries are enrolled in Medicare Advantage, which is the combination of Medicare's Part A, B, and D. And yet the evidence is, if anything, favors that fee-for-service has been lower cost, although I'm always skeptical of the way they compare those two groups. Do you have?
Well, I would say I'm generally a fan of Medicare Advantage. I don't, I think where you see it, it's now up to well over a quarter of Medicare beneficiaries.
It's
now,
about 28%.
It's popular, you know, so whatever that means, you know. And it's doing very well in rural areas. And God, I wrote a paper on this a couple of years ago, and I'm trying to bring it back to mind. There were Medicare Advantage fee-for-service plans. I think they've been wiped out now. I mean, that didn't make any sense at all. And in the, you know, I would change the way they bid. I don't like the way they bid. I mean, I think that I don't want to waste everyone's time talking about the technicalities of how they bid, but I think there is some evidence that they do good for Medicare patients with chronic illness, because they do have the ability to get the incentives better. Sorry, I'm drifting away. I had a clever thing to say. I'm drifting away. Sorry.
I mean, I think the answer for Medicare Part C for these Advantage plans is actually pretty clear. So for the same patient, you actually get better outcomes from the Medicare Advantage plans. It just costs a lot more money. And the reason it costs a lot more money is because of the lobby that's turned out that reimburses the Medicare Advantage plans more on the dollar than you get for Parts A, B, and well, A and B. So you pay them more, and then they deliver better outcomes, but they're doing more at a higher price. So fundamentally, it's because of this link between the insurance lobby and Congress. And if you broke that, they'd be doing a lot better. I mean, there's two narratives here. One narrative is that Medicare is the victim, where if you just got rid of the private sector and expanded it, they do pretty well. The other is that Medicare is the villain. If you got rid of Medicare and you just let the private sector rip, everybody would do better. And I think what you're seeing is a sort of split between the two. I'm a little more on the side that Medicare is the victim, and if you allowed more price control into the rest of the market, you'd probably see better care at a lower price. I think you're on the side that we just should probably scale back Medicare.
Well, the other problem, it just came to me what I was going to say, Medicare Advantage, you get a lot of, I'm not happy with this giving free gym memberships to seniors and all that stuff. I think that's, you know, it obviously pads the costs, and it's evidence. Again, I don't want to take up everybody's time here with the HCC risk adjustment system, but that's far from perfect. So
it's a dollar.
Yeah, the hierarchical criteria, you know. So
see, markets don't work. This is really
well, yeah,
the incentive was not enough. So I actually have worked in Medicare Advantage both on the provider side and on the payer side. And I would say that there are a number of issues with the way Medicare Advantage has been traditionally set up. And I don't know if anybody wants to bother pulling it up on their smartphone, but the announcement was supposed to be made today, like between 5 and now, what the rates were going to be for next year, which is going to do a lot to determine how Medicare Advantage's sustainability going forward. Having said that, some of the issues around it are, I think in general, Medicare Advantage HMO type systems that tend to be more closed and require more coordination and integration and care have been the more expensive organizations because they're doing that coordination. That costs money, but with the higher outcomes. Where you've really seen it fall off is Medicare Advantage PPOs, which is a preferred provider organization where you can go to any doctor you want and there are fewer rules, there's not as much burden on the patient, and certainly the Medicare Advantage fee-for-service programs, which were really, frankly, just kind of a sop to the insurance agencies. So I think that a lot of it has been the way it's been set up. Finally, I would say that another issue with Medicare Advantage is that in many, but not all markets, the health plan managed the risk of doing business by trying to pass as much of that risk on to the physician organizations. And a lot of the physician organizations who took this on weren't particularly adept at managing it. Yeah. And so they ended up basically blowing through their budgets and spending more than was anticipated.
I'd like to go back to a point actually Neil made a few minutes ago about the orthopedic example where there weren't any measures. I think there's an important point there that I'd like to make, which is we are really, I think, at the infancy of being able to measure true clinical outcomes. And I think, you know, we need better data systems. We need better analysis because I do believe, you know, I've seen it. I manage physicians every day. Physicians will respond to incentives around quality. The issue today is we are woefully unable to really measure good outcomes. Most of the measures out there are process measures. They're not bad measures, but I just don't think we're at the point yet in our system where we can have good data, feed that back to physicians because they will change behavior. I think the same is true around care coordination. So, you know, one of the reasons I think things failed back in the 90s were people just weren't able to manage populations of patients. And I think what you see today on the cutting edge of real good big data is that ability. But we have to have a major push, and the investment has to happen through health systems and other places, but to get good data in place so we can, A, measure the outcomes, B, incent people on those outcomes, and C, be able to manage large populations of patients in the most efficient way. None of that's going to happen until we have better data analytics.
I will say just my own experience, I think when I interviewed for residencies, every single hospital I interviewed at told me how they were on the cusp of having an electronic medical record available. And the Brigham and Women's Hospital told us they already had it. And here we are, again, 26 years later, and we are finally implementing electronic health records in most major hospitals. It's not, I think MGH is just about 2 years down or 18 months away from doing it, and Yale New Haven Hospital, being a somewhat better hospital, is a little bit ahead of that curve. But we are in that.
They dismantled it and built a new one.
That's right. So it is a convergence of both better evidence, the electronic health records, changing incentives, and all that does give me personally hope about that. We've got about 10, I'm going to let you speak, but we have 10 questions submitted by text so far, and I'm going to keep pulling them out now. And so if you have any more questions, please keep sending them in, because I'm going to keep looking at them. I'm going to let you have 45 seconds.
Okay, a colleague of mine likes to begin his talks with a slide up that shows a quote from Health Affairs, and it says something like, now that we've gotten to this level of technology and this level of political integration, physicians will be able to make more, better, smarter, faster decisions at the point of care, and therefore can take financial risk, and everybody reads it and agrees with it, and then he reveals it's for 92.
Right. I couldn't agree more.
So I'm a little worried about this happening again.
I'm just finally an optimist. I spent my entire life being Eeyore. I'm finally an optimist about this. I'm going to give a question that is from the audience that is, I think, relevant. I think, you've got to remember, most of you are either medical students or pre-med or already physicians. And the question is, and I'll ask each of you to give a quick answer, will disparity of income between dermatologists or specialists in general, radiologists, we can pick on them for a while, and primary care physicians normalize in the next decade?
Depends on what you mean by normalize, right? No, I think you will see some convergence. I'm speaking slowly because I'm not, totally convinced that. So, I work in this space every day, and I can tell you that there is some pressure on subspecialist incomes. There's certainly upward pressure on primary care incomes. Being a primary care doc, I think that's a good thing. I think it's a good thing also because I think we need more incentives there. So if I had to make a prediction, I would say, if you look at MGMA data, you've seen 7 to 10% increases in primary care compensation over the annually over the past few years. I think we'll continue to see that trend. You haven't seen subspecialty income go down, but I think that could happen, and some of that are market dynamics as well.
I would agree. The gap's going to narrow. I think primary care is going to do better. I think the leading organizations in the world, Kaiser, for example, has a much smaller ratio from lowest paid to highest paid physician of any health system in the country. Yeah. The world's going to look a lot more like Kaiser in 20 years. So that's my answer.
So I think that primary care compensation will go up, but the role will change. So it'll be a trade-off, I think, which is to say that primary care, it is much easier to fund a One Medical, which is an innovative medical primary care practice, or a Take Care or Minute Clinic, or a fill in the blank. It's easier to seize ground from the primary care physician. There's a looming primary care shortage, which is going to also help to drive up salaries, but some of that role is going to be concentrating the primary care physician on the 10% of the people who are spending the 70% of the healthcare dollars, and using nurse practitioners and or PAs to do, physician assistants, to do most of the rest of the routine primary care.
I take a 10-cent commission on every dollar that goes your way.
Do you want to comment on?
Well, I don't want to answer the question, but I just think that there will be change, but I think it's going to be, we have these events at these academic medical centers, and we hear about these great ACOs and stuff like that, but that's not what people out there in America are seeing. What they're seeing is the standard now we're coming to for a person out there working a job is a $5,000 individual deductible and a $10,000 family deductible. That's going to be the standard in a year or two. And that's going to, I like the patient paying, but I think these are perversely designed benefits. And they're going to not want to go to the primary care doctor because it costs so much. They're going to the Walmart where the Minute Clinic is. That's where they're going to go and get it for $79, until it gets too late and who knows what this lump is or whatever. So something weird is going to happen. And I don't know how it'll affect physician payment, but I think it will cause changes between the specialties.
Can I jump in and,
Sure.
just I'm agreeing with a lot of the stuff Neil is saying. I do think, I think how we deliver primary care is going to change, and I think anyone thinking about primary care, I would agree with what Neil said. I think the role of the physician, I actually don't believe there's a physician shortage. I think we have huge inefficiencies on how we use physicians. So, I go to my physician's offices and they're sitting there henpecking their notes into Epic. It's insane. And my point is that you've got the highest trained person, and somebody who's extremely capable, doing data entry. And my point is that we need to develop more efficient systems, because I personally don't believe we have a really big physician shortage. I think what we have is a physician misuse. And I think primary care physicians are going to be team leaders. I think primary care physicians could have a panel of 10,000 patients and then have a staff of folks working for them. Most people who come into a doctor's office, some of them need to see a doctor. A lot of them don't need to see a doctor. They need to see a nurse, they need a care coordinator, they need an a nurse practitioner, physician assistant, and that to me is the healthcare model of the future. Why do we have CVS and Minute clinics? One reason: access. Nobody goes to CVS because they think they're going to see some great doctor. They go there for one reason: because they can't get into their doctor's office, and that's changing in our system now. And so there are incentives changing. I think there's a lot of transparency. And I think you're going to see those changes. And again, my message here is how we deliver primary care is going to be radically different 10 years from now.
And I think that it's going to end up being a real sea change, a real game changer, the way the creation of the hospitalist was, right? I mean, 30 years ago, it would not have been considered that it would be a routine specialty of medicine, that there's somebody who is trained at taking care of people who are sick enough to be in the hospital. I think the role of primary care is going to be the sick peopleist, right? That they're going to specialize in those really complicated patients at the top of the pyramid that are driving healthcare costs, and being involved in coordination of care, balancing off multiple comorbidities, making sure that all the specialty input is taken in and synthesized, and the role is going to be so different that they're really just going to be focused on the sickest.
So I'm going to give you a question that was from the audience. The question really relates to kind of the Medicaid and the currently uninsured population. We have probably 55 to 60 million people that are on Medicaid. Almost all of them are below 200% and generally below 133% of the federal poverty level, so they're probably below $15,000 in income. So they're truly, truly impoverished. And they're not going to be spending out of pocket any large sums. They really can't afford Minute Clinic. And yet our healthcare system serves them modestly at the primary care level and very, very much imperfectly at the specialty level. What types of changes do you propose as someone who's, pro-market to resolve that challenge?
Well, we sort of have a proposal at National Center for Policy Analysis, and it is, we don't like Medicaid largely because, as you pointed out, there's really bad access to care. So when we hear that, the PPACA law, the ACA, increased access to Medicaid, that doesn't get me and my colleagues very excited. That they're not really going to get the sickest Medicaid patients, they're not going to get access to care. And it costs about like $8,000 per family is kind of the nationwide average Medicaid cost. I don't think we have a perfect solution to that, but we would rather that money go to the individual and the individual decide what health plan they want to subscribe, not the county or the state or whatever's going on in your state. But there are some problems that are very difficult to solve. And if you look at Canada, low-income people have lower access to care than higher-income people, and that's a universal single-payer system. It's kind of it's something that I wish we could solve 100%, but I think only individuals can solve it in their community. And I don't think there's a big government solution to that. And I don't know, Professor Cooper could probably give us a bit more advice on I know he's an expert on the National Health Service, but in the National Health Service, they talk about the postcode lottery, right? That your access to specialist care depends on what your postal code is. And again, that's a single payer, government-run system. So
Yeah, I mean,
Sorry, that's the best I can say.
Yeah, I mean, so every doctor, every patient in England has a choice of any doctor in the country now. So they've actually gone in the opposite direction. So I actually like markets too. And I think what I would say for the Medicaid challenge is separate is very seldom equal. And I think that's fundamentally the problem. What I'd love to see is that the exchanges got opened up to Medicaid beneficiaries. And what you said is you'll give them a subsidy, you'll make the care affordable, and you'll allow them to opt in. So you really didn't see this break where Medicaid recipients were getting a fundamentally second-class product.
And a number of states are moving in that direction. I mean, a number of states did get waivers from the feds to be able to take the funding that would have gone into Medicaid expansion and use that to help subsidize getting Medicaid patients, getting patients who would have been put into Medicaid, and subsidize them buying private insurance.
Yeah, and I think just to echo that, since we're coming to agreement, let's keep the ball rolling here. That because we're all going out to dinner together, so let's have a complete dinner. Especially since there are some people who are really poor for all their lives, but especially since 2008, people move up and down the income ladder, right? And there are people who will be in. I'm trying to remember the data. If you're on Medicaid, there's a 50% chance in the next year you will either still be on Medicaid or in employer-sponsored health care because of this. If you're somewhere between 150% of the federal poverty level, you'll have a job, you'll lose your job, then you'll get a job in a warehouse somewhere, and maybe it's got benefits. This fragmentation is really painful, and especially if you've got a chronic illness or, the crazy thing about this country, if you get diagnosed with, say, cancer in January or February, your choices will be very different than if you get diagnosed in November and December because you may be changing your health plan, either with the same employer or something else, and the whole cost structure you face will be different. So I think what Professor Cooper put forward was a very good proposal, that will allow the people to have a continuity of health plan no matter what kind of where they are. If they lost their job, are they back in a job, whatever, that continuity I think would be quite valuable. So,
if I can piggyback, I think that's one of the things that a lot of people can like about ACA, even if they don't like really significant parts of ACA, is the fact that the insurance and the employment are no longer tied together. I mean, getting your insurance to your employment is an atavistic remnant of World War II. And when the benefit package was created as a way to get around wage controls. And so it is a illogical system. And what it does is it will free people up so that if they're going on that yo-yo, they don't necessarily have to be put into a Medicaid type system, and allows people to buy an insurance plan that's most right for them. I will tell you that if you go to a conference like AHIP, the America's Health Insurance Plan Conference, everybody in the room has the same strategy for health insurance now, which is have a managed Medicaid product, have an HMO product that's in the exchange, and then have a Medicare sup and a Medicare baby, depending on the rates, a Medicare Advantage program, so that theoretically, way some people drive Toyotas all their lives because of their brand launch, if the patient can buy on the individual exchange, they may stay with you as a customer from the moment they buy until literally they're in the Medicare population using your MedSup or your Medicare Advantage.
I'm going to, first of all, we've gotten over 22 text questions, so I'm trying to incorporate them and factor them in. So we're doing really well with that. Two-part question regarding the ACA. One is, given the changes that are already happening in the ACA, including, as Dr. Nordgren mentioned, some of the Medicare Shared Savings Program pilot projects and the ACOs and the Pioneer ACO projects, and given those changes that are occurring, how much do you think that's going to impact specialties? And looking at this audience here, what do you advise them about making a choice of specialties given the types of changes that are likely to occur over the next decade? And then the second part is, how much do you think that the ACA has successfully or will successfully address physician compensation issues going forward, if you think there's a problem to begin with? And we'll start with Dr. Nordgren and work this way.
What I'll say about picking a specialty when I talk to medical students, the first thing I say is, pick something you love, because if you want to be a surgeon, you're going to spend a lot of time in the OR. And same with pediatrics or internal medicine. And the point I'm leading to is I hope people can pick specialties based on what they love and not what their student debt is, because I do think that's a significant driver. And it is. I mean, you know, I graduated with 6 figures of student debt when I graduated from medical school, and that was, you know, 15, 20 years ago. And so my hope is that some of the changes happening in healthcare, especially if we do see some compression, will lead medical students to be able to choose based on their interests and what they really gravitate to. In terms of the ACA and the changes, I do think that I think we're going to see shared savings stick. It's in the private marketplace now. I can tell you every contract that I'm negotiating for our medical group right now is a shared savings contract. It basically mirrors the accountable care organization model. So I think that is here to stay. And I think the changes you see with those payment models are going to translate into physician compensation changes, leading to more measurement of quality metric, leading more to more reimbursing physicians based on population health metrics.
Cool. I mean, I'll be sure. I don't have a whole lot to tell y'all about what specialty to choose.
Just go with derm. They're all
yeah, exactly. Dermatology, apparently. I think vis-a-vis the ACA, I think we've got to look at the reason that it passed and the reason that most of the big interest groups supported it. And I think the reason they did was because it didn't take a big whack at anybody. I think all of the uproar about the ACA was mostly politics. I think the ACA is actually really, really conservative in the sense of non-ambitious health policy. So I think if you all closed your eyes and didn't listen to what was on Fox News for the last couple of years, I don't think you'd notice the ACA got passed. So I don't think it's going to make a big difference to physician compensation.
I'm going to respectfully disagree. It's always dangerous to talk about economics next to an economist because they can really make you look foolish. But thank you for not doing that so far. I hope. I don't look foolish, do I?
We've got some time.
The night is young.
It gets to something that was said earlier by you, Dr. Norgren, which is somebody, to cut costs, somebody has to get less. The money, it's not a random dollar that falls from the sky. That dollar is no longer going to be in somebody's revenue stream. And what we are seeing is, with the rise of the exchange, are narrow networks where to be a provider in the exchange network, one has to take a pay cut. Or to be in that particular plan to be able to hit the premium levels that are set by the exchange, there's a reduction in overall compensation. I think physicians are way more vulnerable than hospitals right now in terms of being the entities that are cut. I think a lot of the discussion about, you know, I think it was something like half of the people in the country who make over $300,000 a year are physicians. And that's not something that the public was particularly happy about. And it's not necessarily a positive thing that people aren't happy about that, but it's an easy issue to demagogue, whereas most organizations, most people, most of the members of the public, and certainly most members of the House of Representatives want to save their little community hospital. So I think that the easiest place for there to be savings are tighter reimbursement around pharmaceutical products, to your Avastin point, and a reduction in physician payment. I do think it'll be specialty driven.
Dermatology.
Greg, you don't like them?
So I've agreed with most of what Neil said tonight, but I've got to take issue. You know, I think what you're seeing now economically is actually, you know, hospitals are the ones whose ox is being gored so far. Okay. And I think, so 2 points on that. Number one, I think it's too early to say, gee, you know, physicians' salaries are going to go down. And my point is that I think most of the major cuts you're seeing are coming out of the hospitals. Now, what I think is unknown is how does that sort of trickle down through hospitals? It could trickle down to physician comp. But I think, you know, if you're running a hospital in the health system, your mantra is, I'm going to get less money in the future. I think if you're out in a medical group, and the medical groups were favored by the accountable care organization, i.e. ACO, you know, how those things were structured. So I think, you know, a lot of the ACA does favor some of the medical group dynamics. And so what I think is going to be an interesting thing to play out is, do you see physicians staying fairly stable, but the hospital's really taking the hit? Or does some of that trickle over to the physician side? Again, I don't have a crystal ball, but to me that's one of the interesting things, because you do see the major medical groups in a driver's seat when it comes to the ACOs.
So I think those are fair points. And I'm trying to look a few years down the road with my hazy crystal ball. I think we could at least agree on this, which is that physician compensation will be riskier. That it will be more based on hitting certain outcomes or hitting certain targets, and it's going to be a lot less about productivity and volume.
So I didn't text myself this, but someone did, so I really appreciate it.
Howie is terrific.
No, there's, one of my pet peeves is that Medicare and private payers still pay for an awful lot of completely useless health care, things that we have proven with not just once, but many, many times that they don't work. And then there are other things that are kind of on the margin. And it seems impossible, when I sat on WellPoint's policy advisory board for 5 years, and I got to hear them say many, many times, it's a lot easier to provide coverage for something than to take it away. You almost never can take away coverage for something, even when the evidence comes out saying that it doesn't work. So my question for you, and particularly for Zach, because he said he wants this Federal Reserve for healthcare, and I'm with him on that, but politically, I'm just curious to know, how do we change the culture in this country, and how do we make a movement so that we start paying for things that have an evidence basis for it, and at least stop paying for the low-hanging fruit, the things that absolutely don't work, and we've proven that they don't work, and yet they're widely used because somebody, some individual physician is able to say, I know that the evidence says this doesn't work, but in my hands, it works. How do we change that?
Easier said than done. I think in the private sector, it's a combination of probably exposing patients to more costs, which is happening now, and actually hasn't made a huge impact in reducing spending, but exposing them to more costs and also giving them more information. And I think United Healthcare is the best example of this, where what they'll do is offer the patients a lower copay for going to better providers, or providers who have better outcomes and are offering more evidence-based treatment. So I think something like value-based insurance design, where what I would do as an insurer is say, look, you've got 3 types of drugs to treat depression, and I'm going to offer my copay as something that's inversely proportional to the efficacy or the quality of that drug. So for a drug that we know is generic and does a great job, we'll have a low copay. For a drug that isn't terrific, that doesn't show great outcomes but is quite expensive, we'll make the copay higher. And so we're going to see a lot more sophistication on the copay side, and I think we'll bring in information and incentives together.
So I think, I don't think the payers are going to drive this. I think the physicians are going to drive this, and I'll give you a concrete example happening right here in Connecticut. So there's a 300 physician group called ProHealth, mostly along Route 84. They have a compact now that specialists have signed on to across the state. And they're an ACO. They have shared savings arrangements with all the private payers. So they're getting everybody in the barn. And then I was at this meeting with their president last week, and he said, next year, we're going to steer our patients to the providers that follow these guidelines that we're setting and that are lower cost. And I think one point I would make is a point I made earlier. You have to be able to measure that. So I think, going back to Howie's question, none of that happens until you can do good measurement. But then I don't think the insurers are going to really drive this. I think it's going to be physicians who now have the economic incentive. So because every dollar they save, on unnecessary costs that's not provided is in their pocket, or some percentage is in their pocket. So you're seeing growing incentives to manage care proactively, and the measurement systems that enable them to do that.
No, I think that's accurate. I mean, it was only under, risk deals that we got any of our physicians back when I was working in hospitals in the Boston area to care about, what rheumatoid arthritis or Crohn's drugs or whatever were being used and what was the pathway that was being followed. And it was a subject of tremendous concern and interest and frankly infighting. And then the risk went away, and I never heard about it again from the primary care community because they weren't on the hook anymore. And the management went back to the payers. And I think that also, though, to make that happen, a big step to try to make that happen is your idea of making sure that Part D gets lumped in with A and B. Right? I think that was a pioneer ACO failure, was to not have Part D, the drug benefit, in there, because there were absolutely ACOs who said that the easiest way for me to show a quick reduction of costs is to take all of my patients on IV arthritis drugs and move them to self-injected ones. So it's just not in my bucket anymore.
I mean, so I think it's, again, I keep going back to Kaiser, and I think the example worked well here again. There are cowboy doctors out there who at the margins are just plainly more likely to provide care. And there's, we can pick a number of examples, when you'd order a scan, when you'd put in a cardiac defibrillator, and you just see variation. And the question is, are you going to change those cowboys into folks that are more in line? And I think what a lot of the leading organizations, both on the payer and the provider side, have said is no. It's been ingrained in their training. There are clusters of them. We can't change them. And what they've done is they've tried to keep their patients, who they think don't need the surgery, from getting to the cowboys. And so what Kaiser will say is, look, based on our clinical algorithms, we don't think this patient really needs I'm going to use a stent, even though it probably isn't a stent, but we don't think this patient needs a stent. As a result, we're just not going to send them to the cowboy patient who always puts in stents. We're going to send them to the guy who we know doesn't put in stents. And they do a better job matching patients to providers. And so I think the scope of changing physician behavior is very, very tough. I think the scope of changing where patients flow around the system has a lot more room for making a difference.
There's actually a company called Kairos that's being developed that measures exactly that, and it's a patient-physician matching tool. It's like Match.com to pick your doctor, but in terms of the referral pattern to who are the clinicians that are most likely to operate, most likely to watch and wait, et cetera.
So, I think just one other point that I'll tack on, if we need to make some provocative statements here. I mean, I think going back to the insurers and what are they going to do, I think if anything the last 20 or 30 years shows us is I think the insurance companies have been completely unsuccessful at trying to dictate or sort of modify care. The same goes with care coordination. I think where you see success, I agree with the Kaiser model, but it sort of makes the point. Where you see successful management of care, it's happening at the provider level. And I think our insurance, to me, if I was running an insurance company, I think there's an identity crisis out there. And you see this with the Anthems and the Cignas and the United. They're all sitting in their boardrooms trying to figure out sort of what are we going to do in 10 years? Because I think there's a real question on the table, what is their relevance? Especially when I think physician groups, health systems really start to manage care better.
Well, I'm going to agree with Dr. Nordgren in the sense that if you look at an automobile today and look at the improvement in the utility of an automobile, how much of that came from Geico or State Farm? None of it. I mean, insurers are not, why would an insurer be able to tell a doctor or a hospital how to do its business better? I mean, I don't want to use the term entrepreneurship, but innovation just comes from providers. I mean, consumers don't know what they want until providers innovate and kind of tell them what they want. But in terms of the cowboys, just to throw it out there, recently, a few days ago, HHS said they're going to release the physician payment data, right? So, like Elizabeth Rosenthal at the New York Times every week will be able to write about, this guy puts in 10 stents a day, and that guy does this and that and the other thing. So there'll be a crowdsourcing of the shaming of the cowboy physicians, I guess. I don't know if any of the panel has comments on that. But
I think you're seeing more transparency, and I do think whether it's price transparency or, Zach mentioned variation. I mean, variation is the enemy of quality. I think Deming said that. I certainly didn't think that up. But, I think what you're seeing is an increasing transparency on all kinds of healthcare data, and to me, this is another example. I mean, I tell our docs who push back on having patient satisfaction surveys and, what kind of, say, look, if we don't do this, it's going to be on Yelp. You are on Yelp now. I mean, I think, people laugh at that, but it's true. I mean, all of this is getting more and more transparent, and I think it's a good thing.
I'm going to use that as an opportunity to wrap up. And first of all, I think the panel did a great job tackling a challenging topic. I hope that you all got a lot out of it. I can tell you we got over 25 text questions, and obviously we only got to a few of them. I think they're all great questions, so I'm sorry we didn't get to all of them. But I really appreciate all of you coming. I appreciate Jeremy and all of you for putting this together. And most of all to the panel for coming up here and spending this time. So thanks very much.